airspace disease, which is rather unusual. This is an example of what a mixed pattern looks like. You can see some areas are kind of hazy, some areas are completely opacified. That's an example of what mixed disease looks like. Okay, any questions about those patterns?
Which one is the mixed disease?
Say again?
Mixed disease?
Mixed disease.
Something different than the other two?
It's a mixture of interstitial and airspace. Mixed. Mixed. Okay, we're going to take a look now at bacterial pneumonias. We're going to take a look at these pneumonias caused by typical bacteria. Naturally, this causes airspace disease. We're going to take a look at the different patterns of airspace disease. Now, we did say that airspace disease infiltrates the alveolar spaces, the alveolar air spaces with a lot of pus. However, based on the anatomic distribution of the infection in the lung, we can subclassify these airspace diseases as either lobar pneumonias or bronchopneumonias. These terms specifically refer to the anatomic distribution of infection throughout the lung. Now, most important thing to remember about lobar pneumonias is that they are a primary infection of the alveoli. The alveoli are primarily infected by the bacteria. Bronchopneumonia, the most important thing to remember, they are a primary infection of the airways. And that infection secondarily involves the alveoli. So we got lobar pneumonias, which are primary infections of the alveoli. And we got the bronchopneumonias, which are primary infections of the air spaces that secondarily involve the alveoli. Let's talk first about the lobar pneumonias. In lobar pneumonia, have a primary infection of the alveoli. Bacteria get in the alveoli. The bacteria start to spread through the lung from alveolus to alveolus, and they will continue to spread through the lung until they hit a natural tissue barrier. Usually, a natural tissue barrier is a lobar fissure, or perhaps even the visceral pleura of the lung. Those are natural tissue barriers beyond which the bacterial infection will not spread. As a result, if the alveoli get infected, and the bacteria start spreading out until they finally hit these lobar fissures, kind of wall of the lung, generally they can involve an entire lobe of the lung. And as a result, an entire lobe of the lung becomes consolidated. We call that pattern a lobar pneumonia. Let's take a look at an example of lobar pneumonia. You can see why we call it lobar pneumonia, because an entire lobe of the lung is infected. Okay. Here's an example of a right upper lobar pneumonia. Okay, it'd be caused by something like pneumococcus, okay, the Streptococcus pneumoniae organism, which is a typical bacterium. Let's take a look. We've got a frontal projection here. You can see, again, right upper quadrant completely opacified. Lower quadrant looks nice and lucent. Left lung looks nice and lucent. The only opacification we see is in the right upper quadrant. Take a look at the lateral profile. You can see we've got a very sharp demarcation of opacification here on the right upper quadrant. That corresponds to the right upper lobe of the lung. And so we have a right upper lobar pneumonia. Notice the consolidation here is very tightly, has a very tight, sharp boundary. Okay, doesn't really spread beyond that boundary. That's because there's a natural barrier there. There's a lobar fissure there. You've got, of course, the other boundaries, and the entire upper lobe of the right lung has become infiltrated with pus. There's a lot of pus in the alveoli, and it's isolated to one lobe. So this is what we call a lobar pneumonia. Okay. Now, again, lobar pneumonia just refers to the anatomic distribution of infection, and the entire lobe is consolidated. Let's take a look at the gross appearance of a lobar pneumonia. Here's a section through the left lung. Okay. We've got a coronal section through the left lung. You can see the upper lobe of the left lung. There's the lower lobe. There's the oblique fissure. Right up, the upper lobe of the left lung looks pretty good. Okay, you can see the visceral pleura up here, cut surface here. Everything looks good. Okay, this has been fixed in formalin, so it's kind of a brownish color. There's an area here that's pink. That's simply unfixed. The formalin didn't get to it properly, so it's a little area of unfixed lung. Everything looks good. Nice smooth surface here, granular. That's because there are lots of alveoli there. Lower lobe of the lung, you can see, has a kind of yellow-white cut surface. And that's because all of the alveoli in this area are filled with pus. If you squeeze this lung, pus would exude from the cut surface. Okay, this is a complete consolidation of the left lower lobe. And again, you can see it's restricted to the left lower lobe. There's a very sharp demarcation between infected lung and non-infected lung. This is a good example of a lobar pneumonia. Now, if you take a section through this part of the lung, you know what you're going to see. You're going to see airspace disease. Okay, all of the alveoli here filled with pus. And that's going to present with solid consolidation on the radiogram. So that's an example of what a lobar pneumonia looks like. Let's take a look at what bronchopneumonia looks like. So bronchopneumonia is not a primary infection of the alveoli. Primary infection is with an airway. But it just so happens the infection incites inflammation in the airway, and that inflammation secondarily involves the alveoli in the immediate vicinity of the airway. And so you don't see an entire involvement of a lobe of the lung. Instead, you see kind of patches of the lung infiltrated with pus. That's what we call a bronchopneumonia patch. Let's take a look at this. Here's an example of bronchopneumonia. Again, you can see it's airspace disease here. You got areas of solid opacification, but they're kind of scattered. They look like kind of fluffy areas throughout the lung. There's no single lobe that's actually consolidated. So you just see these kind of areas here that are focused, and they're kind of all fluffy infiltrates. Lots of pus in those areas. This is because an airway in this area got infected. There's an airway right there. Okay, the airway got infected, and because of the inflammation incited by the airway infection, the inflammation kind of involved some of the surrounding lung, and it just kind of spread out from there. Okay, this is an example of a bronchopneumonia. Let's take a look at the gross appearance. Bronchopneumonia, section to the left lung. Okay, again, fixed lung, cut surface, apex here, base here. Again, really good cut surface here. There's nothing wrong with this lung. This looks all healthy. There's a little some carbon deposits there, a little anthracosis there, but otherwise the lung tissue looks fairly healthy. Okay. Take a look through the rest of the lung. You can see these little patches of yellow discoloration. All the patches of yellow discoloration in the immediate vicinity of an airway. This is typical of bronchopneumonia. And what's happened here is that airway got infected, and the inflammation secondarily involved the alveoli in the immediate vicinity. All the alveoli in the immediate vicinity filled up with pus. Okay, and then you have this kind of very patchy looking kind of areas filled with pus. And that gives rise to that patchy area of consolidation that you see on a radiogram. That's an example of what bronchopneumonia looks like. Okay. Strictly speaking, a lobar pneumonia, bronchopneumonia, again, they're just descriptions of the anatomic distribution of the infection. The relative importance of, not very highly regarded. Infections and infections, you got to deal with this. Whether it's a lobar pneumonia, bronchopneumonia, basically tells you the extent of the infection. Okay? Doesn't really affect the way that you're going to treat, at least with antibiotic. And so, lobar pneumonia, what's lobar pneumonia, what's bronchopneumonia? Again, it's just a description of the anatomic distribution of infection. Okay, any questions on that? All right, let's have a look at some specific infections. Again, I'm sure these were mentioned in micro, but let's take a look at some major infections. Okay, pneumococcal pneumonia. That's an infection with Streptococcus pneumoniae. This is the most common community-acquired infection. When we say community-acquired, we mean a person who's not in the hospital, they're generally healthy in the community. If they're going to develop a type of pneumonia, very often it is pneumonia caused by the pneumococcus, Streptococcus pneumoniae. Now, it's very likely that Streptococcus pneumoniae will present with a lobar distribution of airspace disease. Naturally, it's a typical bacteria. So it's going to present with airspace disease. Person with the infection is going to be coughing up a lot of sputum. Very often, this organism primarily infects the alveoli, and it spreads through the alveoli until it hits natural barriers, and so usually an entire lobe is consolidated. So it presents very often with a lobar pneumonia. A couple of risk factors tends to affect extreme age. People of extreme age are very young, very old. People with comorbid conditions, like, for example, congestive heart failure. Congestive heart failure tends to fill up the lungs with some fluid. Bacteria like to thrive in that fluid. Okay, that's a risk factor, basically presenting the organism with a medium in which to grow. COPD, like emphysema, diabetes. Okay, nice sugar-rich fluids in the lung. And alcoholism. Alcoholism tends to impair the gag reflex. Gag reflex, as annoying as it is, you kind of aspirate down the lungs, accidentally start coughing and hacking, and you can't stop coughing and hacking. As annoying as that is, it's actually necessary to prevent some type of aspiration pneumonia. People with who are alcoholics, the alcohol kind of suppresses that gag reflex, that cough reflex, and they're more likely to aspirate without clearing the lungs by coughing, and they're more prone to developing these types of pneumonias. Now, the etiology of a pneumococcal pneumonia generally is one in which a person aspirates their own pharyngeal fluids. In some people, the pneumococcus is a normal symbiont of the oral pharynx. It's part of the normal oral pharynx flora. And so usually to contract an infection with pneumococcal pneumonia, you have to aspirate the organism. It gets down in the lungs, colonizes the lungs, and you develop a lobar pneumonia. Okay. Now, usually when this happens, when we accidentally aspirate this organism into our lungs, very often it's not productive of an infection. And that's because your airways, lungs, are all lined by protective epithelium. That epithelium is the first line of defense you have against bacteria. It acts like a blocker. As long as it's intact, the bacteria have a really tough time penetrating. So even if you aspirate the organism, chances are you won't develop any kind of significant infection because the epithelial cells just won't allow it. It won't allow the bacteria to invade into the lungs. However, sometimes when a person has some sort of viral infection, and they have a bad upper respiratory infection, they have a cold, they have a flu or something like that, the virus will cause degeneration of the epithelium. And when you lose that epithelium, you lose the first line of defense against bacteria. So very often what happens, very often the history you get from a patient with pneumococcal pneumonia is they will tell you just 1 week earlier they had a bad flu or bad upper respiratory tract infection. And then now they're complaining to you, now I got pneumonia. Okay. The two are not unrelated. The two are actually dependent on each other. One caused the other. Person had that viral infection that degenerated the epithelium and left them defenseless against an event in which they aspirate the organism in their lung. They aspirate the organism in the lungs. Now, without that protective epithelium, the organism has a much better shot at infiltrating the lungs. And so typically the history you get from a patient is that just a week earlier, I had this bad viral infection. Yes.
Is it just going to be a virus, or can something else degenerate it? Do they have like asthma or smoking or something else?
All those people are more prone to develop infections. For one reason or the other, cigarette smoking, they destroy the ciliary epithelium, they can't clear the adulterated mucus. And with asthma, they develop airway occlusions because of mucopelline plugs. There's changes in the type of epithelium. There are fewer ciliated cells and more goblet cells. Okay. Any questions on that? Let's talk a little bit about the presenting features of pneumococcal pneumonia. Okay, again, Pathogenesis, aspiration of pharyngeal flora. Okay, presentation. Usually this is a very acute illness, a very abrupt onset, high fever. They develop the shaking chills because of the fever. Their alveoli begin infiltrated with pus, but in addition to the pus, there's often some degree of hemorrhaging into the alveoli. The RBCs mix in with the pus. You got red plus yellow, productive of a kind of a rust-colored sputum. They're coughing of pus. They're coughing of blood. It kind of has this typical rust color to it. Okay. Now, very often when we're trying to diagnose a pneumonia, obviously we want to identify the organism. There's so many different ways of doing that. Usually you first begin with a sputum sample, and you just want to identify the organism typically with a gram stain. You should see gram positive diplococci. The problem with a study like that is very often if you try to identify the organism, pneumococcus, with a sputum sample, you'll get a lot of false positives. And that's because the organism is a normal part of the pharyngeal flora. So even if it's not the cause of the infection, coughing up sputum is going to get contaminated by the oral flora. And you probably identify the pneumococcus, even if it is not the cause of the pneumonia. So you get a lot of positive, false positives as a result of that. We'd rather identify the organism by taking a blood culture. If the person has a bacterial infection, the organism is going to get in the blood. We're going to sample the blood. It'll be there. We'll culture it, and that will prevent any kind of contamination with any other kind of oral flora. We'll be able to just grow out the organism, and that has a lot of benefits in and of itself. It can test for antibiotic resistance in vitro, and otherwise kind of characterize the organism and direct our antibiotic therapy accordingly. Generally, we start the antibiotic therapy, though, empirically. You know, if we think it's like a coughing up a rust-colored sputum, the first thing we're going to do is probably assume it's Streptococcus pneumoniae. We'll go ahead and get the culture, and then we'll just start what we call empirical antibiotic therapy, and we'll wait for confirmation on the identification of the organism. All right. Any questions on that? Pneumococcus pneumonia. Things to remember: pneumococcus, again, a very common cause of community-acquired pneumonia. Person's just fine and living in the community. They're going to develop pneumonia. It's very often this pneumococcus pneumonia. Okay. Antecedent condition: very often you have some sort of respiratory illness a couple of weeks before. All right, Staph aureus. Staph aureus. That is another nasty one. It is a very pyogenic infection. Pyogenic means pus forming, like to form abscesses. Staphylococcus aureus can also be another cause of a community-acquired pneumonia. However, people who develop Staph aureus pneumonias very often, not always, but very often, have a specific history of IV drug abuse. Typically what happens is they inject their IV drugs in the dirty skin. The organism's on the skin. They drag the organism into the central venous system. It goes to the right side of the heart, possibly showers the tricuspid valve. Then it goes into the lungs, showers the lungs. And as a result, people can develop a septicemia. They can develop the condition where the lungs are just showered with a lot of septic emboli of staph, and they develop a staphylococcus pneumonia. A Staph aureus pneumonia is characterized by abscesses. Take a look. Here's a radiograph of an IV drug abuser developed Staph aureus pneumonia. Again, we got a fairly normal lung. Look at the left lung. You got these kind of spherical lesions here. Spherical lesions have a kind of a radiodense base and a kind of a lucent upper portion. These are abscesses here, and this is an air fluid interface above the abscess. Once these abscesses form in the lung, they're kind of tough to deal with just antibiotic alone. We can try to resolve these infections with antibiotic alone. They're probably not going to be very successful. The way you have to deal with these abscesses, you have to go in with a needle, you have to drain them, irrigate them. Usually with an abscess, you have to incise and drain. The abscess usually doesn't allow a whole lot of antibiotic to get into it. And if the antibiotic does get into the abscess, it's a very acidic environment, usually destroys the antibiotic before it has any kind of effect. So usually we have to resort to incision and drainage of these abscesses. Okay, any questions on that? Okay, let's talk a little bit about primary atypical pneumonias. Okay, so we talked about a number of typical agents that can cause pneumonias. Pneumococcus, that's a typical bacteria. Okay, Staph aureus, that's a typical bacteria. Now we got the atypical bacteria. Okay, atypical bacteria would include chlamydia and mycoplasma. Those are some common agents that cause infections of the lungs. In addition to that, we've got viruses that very often cause walking pneumonias, very typical pneumonias, and fungi, which we'll talk about later. So these are the agents that tend to cause walking pneumonias, atypical bacteria, viruses, fungi, and naturally they present with interstitial disease as opposed to the airspace disease we've been seeing. Okay. The most common cause of a atypical pneumonia will be a virus like influenza, okay, A or B, generally affects any age. The next most common will be Mycoplasma pneumoniae. That's agent that is the most common non-viral agent. Tends to affect children and adults, children and young adults. And then we have Chlamydia pneumoniae. Okay, that is the third most prevalent atypical infectious agent that causes walking pneumonia. Okay, all these type of walking pneumonias, people walking around, they're not coughing up sputum. They're coughing, but they're not coughing up sputum, and that's because they all cause a interstitial inflammatory pattern in the lungs. We saw this again, section through the lung. Airspace, beautiful. Airspace, okay. Airspace up here, okay. Interstitium, very thick, and you see a lot of chronic inflammatory cells in the interstitium. These are the type of inflammatory cells you expect to attack viruses and atypical bacteria. Atypical bacteria usually incite a chronic inflammatory response. So all these different agents that cause walking pneumonia usually incite chronic inflammation. Okay, mycoplasma, virus, fungi. Okay, all these things incite chronic inflammatory response. Okay, any questions on that? Anything? Okay.
Well, Dr. Matty,
Yes.
going back just to the staff and the other one, are they both upper respiratory, like succeeding upper respiratory?
Things like all of these different, yeah, thank you. I actually forgot to mention Staph aureus. Staph aureus can also be followed by an upper respiratory tract infection by a virus.
Okay.
So very often what we get is a history of IV drug abuse, but not always. Sometimes we also get a history of a upper respiratory tract infection. Anything else? Okay. All right, next we want to talk about a very confusing disease. It's kind of confusing the way it's presented. Tuberculosis. Tuberculosis has a variety of ways it can present. And because of the variety of different ways it can present, it tends to be a very confusing disease to students. There are a lot of different factors that are involved in determining how the disease actually presents. And if you understand these different variables, it's not such a confusing disease at all. Mycobacterium TB is a type of bacteria that usually causes a pulmonary infection, but usually acquired by inhaling some sort of infectious air droplets. The organism gets into the lungs and it eventually incites a necrotizing chronic granulomatous inflammatory response. And so TB is generally referred to as a granulomatous inflammatory disease. Now, it can affect any organ tissue of the body, but usually, because of the way we acquire the infection through the lungs, it's usually considered a pulmonary disease. It doesn't have to be. It's usually, though, pulmonary disease. Now, the organism responsible is Mycobacterium TB, and it's described as an acid-fast bacillus. The description acid-fast refers to the staining characteristics of the organism. The organism has some unusual fatty acids in its wall that allows it to stain very darkly red with a dye called carbol-fuchsin. Okay. These fats in the wall are called mycolic acids. And these mycolic acids bind this red dye, carbol-fuchsin, very tightly, such that once the organism dyes with this red pigment, you can't wash out the pigment. You can't decolorize the organism. Okay. All right. Let's take a look at the properties of this organism. So usually we use this carbol-fuchsin, this red dye, to stain for mycobacteria. Now, if you take this carbol-fuchsin red dye, you stain tissue with it, it will stain red. It'll stain dark red. However, you can wash out that red color with an organic acid. And as a result, the wash of organic acid will kind of wash out all of this red dye. We say that that tissue is not acid fast, meaning it did not retain its red color when we washed it with acid. Mycobacterium TB is different. The mycolic acids in its wall very tightly bind this carbol-fuchsin dye. And so when you stain it red with carbol-fuchsin and you try to rinse it with an organic acid, you can't rinse the red dye out. And therefore, we call the organism acid fast. Acid fast refers to the staining characteristics of the organism. Because of the odd staining characteristics of the organism, it's actually easy to identify tissue by using something we call an acid-fast bacillus stain, or AFB stain. AFB stain is a 2-chromogen stain. It's got this red carbol-fuchsin that stains the organism red, and it's got this blue counter stain that stains everything else blue. Now, here's a section through lung tissue that's infected with Mycobacterium TB. Okay. We have a lot of inflammatory cells here. They're staining kind of with blue, the blue counter stain. Okay, see some neutrophils in here, some chronic inflammatory cells. And then, of course, we see this slender bacillus here that's staining red. That's the organism Mycobacterium TB. You can see this lung is absolutely infiltrated with the organism Mycobacterium TB. Okay, that's what the organism looks like. It's described as acid-fast slender bacillus. All right, let's take a little time to just introduce you to the ways that this Mycobacterium TB infection can present. It can present a variety of different ways, not a variety of different presenting features. Yes. Acid fast.
Yeah.
It's a property of the organism, excuse me, whereby you can stain it red with carbol-fuchsin. You can't wash out the dye with acid. That's acid fast. Okay, a lot of different variables in the way that this organism can present. Most of the variables depend on whether or not a person's immune system has been previously sensitized to the organism's antigens or not. As a result of that, there are two main ways in which a TB infection can present. One spectrum of features is called primary TB. The other spectrum of features is called secondary TB. Primary TB is a group of features that the infection will present with, providing the immune system has never seen the antigens of TB before, meaning your immune system is naive to this organism. It's never encountered it before. If your immune system's never encountered this organism before, you will present with a spectrum of features that we call primary TB. Primary TB. If, however, a person has already encountered this organism before, their immune system has already been primed to the antigens of the organism, no longer naive to the organism, then when a person becomes infected with the organism, they will develop a spectrum of presenting features we call secondary TB. Secondary TB. And so one of the main factors determining whether or not someone presents with certain features or another set of features really is either the naivete of the person's immune system or the experience the immune system has with the organism. Okay, we're not going to have time to go through it, but let me talk about some generalities. Mycobacterium TB. You get infected with Mycobacterium TB, most likely outcome is nothing. You're asymptomatic. Your immune system recognizes the organism. Okay, it will incite acute inflammatory response against the organism, and eventually will mount chronic inflammatory response against the organism. Then there are some other possible outcomes. Sometimes a person has an immune system that's kind of odd, and it doesn't exactly destroy the organism. Sometimes it allows the organism to spread through the lung to cause what we call progressive disease. When it does that, people are very symptomatic. The organism starts destroying the tissue. People are coughing up a lot of sputum and necrotic tissue. And as a result of that, kind of TB gets its really bad reputation. You know, it's a very nasty disease. People coughing up blood all the time, and a sputum all the time, and necrotic tissue all the time. Another thing can happen with TB. Sometimes the person's immune system is either depressed or otherwise unable to contain the organism at all. And the organism can disseminate to different tissues, maybe the meninges, the adrenal gland, the spleen, the liver. We call that miliary disease or disseminated TB. That's a really nasty condition. It usually only develops in people who have severely depressed immune system. People with AIDS, people with other types of immunologic deficiencies. Any questions on that? Okay. Before we adjourn, there's another issue I'd like to talk about. It's been brought to my attention by a couple of students, actually a few students. It regards the last exam that we took. As I was looking at the statistics of the exam, what struck me was that there's some of the patterns I was seeing were suspicious. They were suspicious in a way that suggested that some people had access to the questions prior to my administering the exam. I was looking at these statistics, and as I was doing so, I received some rather pointed complaints from students who seemed very upset that other students had access to these questions. There were complaints from students who did not like the idea of other people cheating. They were getting one grade, and the people who were cheating were getting another grade. I'm investigating this. And so far, it seems like there is very credible evidence to substantiate some of these complaints that I got from other students. What I'm gonna do about it right now, I'm not sure. I'm gonna have to look at all the statistics and see what happens. I've been talking to the administration about this. It would, of course, be very helpful if the individuals involved in this would come forward and let me know they were involved in this. I will give them another exam. I will not press any charges. I won't do anything about it. I will just reissue them another exam. The other possibility is I have a provision on the exam. And I really don't want to do this, but there's a provision on the exam that would allow me to recall the exam, cancel all the results, and then reissue the exam to everybody. And as you can imagine, this is not what I want to do. And it's a statement prominently featured on the exam. Now, I'm trying to ascertain as to how many people involved in this. I would really appreciate it, and I'm sure every student would appreciate it, if people involved just would come forward to me. We'll keep it confidential. I don't care about prosecuting or anything like that. I just want to spare the students. Some students work really hard studying for this exam and did well. And I don't think it is, I just would prefer to keep this quiet. Let's just re-examine the people who, were involved. We'll administer the exam during midterm. And that'll be the end of it. There won't be any kind of pursuit of any charges. So if those people would do so, they want to take care of this problem, please get in contact with me by tonight. Let me know. If not, or if these individuals don't, then I'm going to have to pursue it further, and there could be repercussions. So I'm giving people the opportunity, free and clear, you can't beat that, versus potential serious consequences.
Don't be a coward. Cheat is say something. No one wants to redo this exam.
No one wants to redo the exam. I don't want to redo the exam. And I've got to make up a whole new exam, so it's not, it's not a party for me. Okay.